about that.
The old plug story. Good morning. So I'm here presenting this on behalf of my colleague, Ian Krupp, who couldn't be here this morning and who's the first author on this study, and we'll be presenting this later this afternoon. So this is the FERGI study, which is a phase 2 randomized trial of the PI3 kinase inhibitor pictilisib. We used to call it by its name, which was easier than pictilisib, plus fulvestrant versus fulvestrant plus placebo in patients with ER-positive breast cancer, all of whom had had a previous aromatase inhibitor, or AI. So the PI3 kinase pathway has been the focus of a great deal of attention over the course of the past 10 years, and particularly in ER-positive breast cancer. PIK3CA mutations, which are activating mutations and lead to signaling through the pathway, are present in 40 to 45% of cases. This signaling mechanism, or this signaling, has been implicated as a resistance mechanism to anti-hormonal therapy or anti-estrogen therapy, both in vitro and in the clinical setting. And the combination of pictilisib and fulvestrant was more active than either agent alone in estrogen receptor positive animal models. Pictilisib itself is an oral, potent, class 1 selective PI3 kinase inhibitor. So this was the design of the study. This was intended as a randomized phase 2 study, which was trying to look for a signal of activity. This was never intended to be a definitive trial. And in this trial, patients who had estrogen receptor positive, HER2 negative breast cancer, all of whom were postmenopausal and all of whom had had a prior aromatase inhibitor, were randomized to receive either fulvestrant, an anti-estrogen, plus pictilisib, or fulvestrant plus a placebo. Patients who developed disease progression were unblinded and in fact were offered the possibility of receiving pictilisib plus fulvestrant at the time of disease progression if they had been on the placebo arm. And there were a number of stratification factors and analyses that are listed at the bottom that we can talk about later if you're interested. In terms of adverse events, there were a greater number of side effects with the combination therapy than with fulvestrant alone. Most of those side effects tended to be gastrointestinal side effects and dermatologic side effects. They were not overly severe in the vast majority of cases. On the other hand, there were more patients who had to discontinue their therapy because of side effects who received combination therapy with pictilisib versus those who were on the placebo arm. These are the results. This is the progression-free survival in the entire patient population. And what you can see is that there is a modest improvement in progression-free survival, but not one that reaches statistical significance. Patients who received placebo plus fulvestrant had a median time to progression of 5.1 months, compared to 6.6 months for patients who received pictilisib plus fulvestrant. And of course, because this was a relatively small phase 2 trial, the only difference that would be statistically significant would be a relatively large difference in outcome. There was an unplanned subset that was evaluated, and that was the group of patients who had not only estrogen receptor positive breast cancer, but estrogen and progesterone receptor positive breast cancer. This is the group of patients who are thought to have the most hormonally sensitive disease because PR helps to facilitate signaling through the estrogen receptor pathway. And within this subgroup, which accounted for about 70% of patients, albeit an exploratory analysis, there was a significant improvement in progression-free survival from 3.7 to 7.4 months. And in terms of conclusions, the safety profile that was seen in this study with pictilisib and hormonal therapy was similar to what would have been expected based on the phase 1 data. It is quite possible that the optimal levels for PI3 kinase inhibition was not achieved because of the need to move forward with dose adjustments in a sizable proportion of the patients. And in terms of efficacy, I think the bottom line is this, is that there was certainly the hope that this would be somewhat more active. On the other hand, there was a small improvement in progression-free survival seen in the overall patient population. And the exploratory subgroup of patients who had ER and PR positive breast cancer is worth looking into further, and there are studies ongoing to do just that. Of note, patients who had PIK3CA mutations, so the mutation that is thought to activate this pathway, didn't seem to have an improvement in outcome with pictilisib versus other patients. And so that in and of itself was a surprise. And I think the bottom line is there was enough activity here that there is certainly interest in pursuing additional research related to this pathway in breast cancer. This is not the only study that has looked at an inhibitor of this pathway, and there are also abundant preclinical data. Whether or not this particular drug is the right drug remains to be seen, and there are now ongoing phase 3 trials of agents that are thought to be more potent inhibitors of the PI3 kinase pathway in combination with hormonal therapy. And I think many of us are actually quite optimistic about those studies in particular. Be happy to answer questions.
So thank you so much, Dr. Weiner, and I think this again shows more evidence that targeting this pathway continues to be important in hormone receptor positive breast cancer. And it also shows us, again, another study that shows us that PI3 kinase has not yet been proven to be a reliable biomarker. In light of this and other trials, do you think that we should stop testing for PI3K as an inclusion criteria?
Well, to begin with, we should only be testing for PIK3CA mutations or other alterations in the pathway within the context of clinical trials, since there are no clinical decisions with commercially available agents that should be based on that kind of testing. That said, some of the newer agents, and in particular what are referred to as alpha-selective PI3 kinase inhibitors, actually appear to be more active in patients who have PIK3CA mutations. And so I don't think we'll see an end to testing as part of either inclusion criteria in some of the trials or as part of evaluating the results of the trials.
Thank you. I'd like to open up the questions to the audience. Any questions for Dr. Weiner?